welcome to MSK Research Brief. This is the inaugural edition of the listener interview. So here I am joined by Naga, and can you pronounce your last name for me?
Vemparala.
Yep, Naga Vemparala, thank you. My name's Michael Post. And so here the whole goal is we're just going to have a coffee shop discussion for a few minutes. We're going to cap it at 15 minutes. We're going to review the content from June of 2020. And so I invited Naga to join me here today, and hopefully you have some interesting thoughts with regards to any of the June content from our podcast reviews. The 4 articles that were discussed were the Fazey article that discussed the lumbar spine looking at the discs. We had the Franz article, which was the observational series, the 2 control arms with MDT in the military. With or without MDT type care for patients with low back pain. We had the Louw study. So the Louw one was looking at how history influences patient outcomes pre-intervention. And then the last one was the Albert study. So that looked at what types of discs do we have, or what types of discs are portrayed on imaging, and what are the effects of an examination, and how likely are those patients to centralize during examination from a mechanical diagnosis therapy perspective with regards to how those images look. So Naga, I'm just going to field to you whatever article you'd like to talk about. The floor is yours.
Yeah, I'm actually a big fan of Joe Nijs et al., where the first article on recognition of central sensitization in patients with musculoskeletal problems, application of pain neurophysiology in MSK practice. That's a great article that I would highly recommend about our fellow clinicians about during our MDT assessments, where we try to classify the patients based on their non-pathoanatomical approach, and also taking the biopsychosocial approach in the MDT evaluation. So I believe this method of evaluation, whether their pain is central sensitization or nociceptive or neuropathic kind of pain, can be a useful tool in our evaluation.
Yeah, good. And that's actually, so that was the Nijs article. I agree. I love the author. It has a lot of really good information. You'll see that was the first week of July content. So that's July is about chronic pain neuroscience education, central sensitization. And in this one I didn't mention earlier is about identifying as a manual therapist. How can you identify patients with central sensitization so then you can go and treat them effectively? And I agree with you there. Mechanical diagnosis and therapy is an excellent base assessment tool in order to screen out that mechanical property. From a musculoskeletal perspective, it's an excellent peripheral system assessment tool, which of course then we can be thrown off when we're encountering primarily a central system problem.
Yeah. Mm-hmm. Yeah.
And so, so walk me through a little bit here. What are you thinking from that article? It talked about what clinical criteria you can use. So primarily talked about listening to the medical diagnosis was step 1, more or less, from that perspective. And then the patient interview, which can lead to clues related to central sensitization. And then some of the clinical examination techniques and kind of following the algorithm. But why don't you talk to me a little bit about your thoughts or perspective related to what that article has to say and how you practice?
Yeah, I mean, learning the MDT method has really expanded my vision on the orthopedic musculoskeletal problems. And previously, I was primarily looking in the biomedical approach, and learn from this article. It can help the clinician to evaluate the patient from a multifactorial approach, where previously I was missing on the psychosocial aspects and the occupational health factors and other yellow flags, orange flags, black flags. So I was not very perfect on those background of the patient's problem. So I was able to inculcate those problems into my MDT assessment or my general orthopedic physical therapy evaluation. So I was able to help the patients. I was able to help the patients on a in a better way, I would say, and I was able to better manage the patient and their musculoskeletal problems.
Yep. And so, for the listeners who may not be quite as familiar with MBT, it's that assessment approach, that theoretical model of using repeated movements to identify what some may say is a true orthopedic nature, the true pain response to an end range movement, to help tease out a little bit more away from that biomedical model as some other approaches might take, to find out the true pain response to movement. And so, before you got into MDT, what sort of biomedical model were you using, or what was your approach to taking these patients in originally as compared to today?
Yeah, I was trained by my professor, who is actually one of the student of forgot his name, but he's actually the teacher of Robin McKenzie, Maitland, and Mulligan in UK. Forgot his. Yeah, so I followed the principles of the general orthopedic practice from UK, but I was able to improvise on the McKenzie method once I started getting certification in the McKenzie method, and that actually further refined my orthopedic assessment and management of the patients. So previously I was more of Maitland and Mulligan based assessments and giving the treatments based on the biomedical model. But once I started, this is not working because it would work only for 3 out of 10 patients in a day. And the remaining 7 patients have no effect with my manual therapy practice. So I decided there is something not working here, because manual therapy did not work for the remaining 7 out of 10 patients in my schedule. So that's why I decided to read more about the McKenzie method and how I can help the remaining 7 patients, and to see whether I can help them or not help at all. So.
And are you referring to either, I think, Kaltenborn or Syriax? Was that any one of those?
Yeah, Syriax.
Okay, there you go. Yeah, good,
sorry.
good. And, and it's interesting because I hear people talk about Maitland and Mulligan as a potential limitation to an approach to therapy. But if you look at a lot of some of the work that Chad Cook's done, they're at heart, they're response-based assessments. But I think a big difference between that and the McKenzie approach or mechanical diagnosis and therapy is the structured or kind of the algorithmic approach, and how you might systematically address a patient with certain directions of repeated movements to work towards that classification system. So what's a big takeaway for you from this Nijs article that we talked about?
I think the assessment method itself, like the systematic method of assessment, how asking the proper history, taking questions, and also following with the physical examination testing, where there is a thorough sequence of things that are going on. That is my best take from that article.
Yeah, good. And my favorite points were, which I've reflected on in my own practice then, is you do get those patients that come in who have a medical diagnosis that are predisposing towards central sensitization. So that's big. And so there's a list of a few of those, like irritable bowel syndrome, chronic fatigue syndrome, the chronic whiplash associated disorder, that really strongly associated. And then there's others that are subgrouping towards central sensitization, like chronic low back pain and some others. And then certainly taking an in-depth interview of the patient, whether it's motivational interviewing approach and you're talking to the patient to tease out a little bit more how they feel about certain conditions, and you can find those fear avoidance types of thought processes that then again further predispose towards central sensitization type patterns. And then the clinical examination, I love seeing the bilateral neurodynamics on this. I use it all the time for my patients with either neck, low back pain. You run into those potential peripheral referral patients. And I really appreciate that from a clinical technique standpoint during examination. Probably stood out the most for me. But let's move on. So we talked about week 1 of July. Let's look back at June, some of the articles. Is there anything else that stood out in particular that you wanted to talk about?
Nothing specifically, but I can expand if you have. I mean, you
Of
can
course.
definitely ask question. Yeah.
Yeah.
Yeah. Nothing
Yeah.
right now. Yeah.
Oh, good, good. So what did you think of with regards to the Franz study? So Franz was again, we talked about that was released, what was it, 2012, I believe, 2017, I'm sorry. The 2017 article is meant to be pragmatic for a number of reasons, and looked at about 44 patients, two different treatment groups. Patients were referred within the Canadian Armed Forces.
Right.
Anything in particular that you found interesting about that particular review or that study? Any lingering questions that you might have with regards to either the results of the study or where to take it from there?
Yeah, the main thing was about identification of directional preference in those patients in the study, and I believe that they are not very specific about the direction of forces, and I think it was more a generalized, such mentioning just like a McKenzie extension exercise um,
Yeah.
rather than the provisional diagnosis based on the repeated movement section.
Mhm.
So I think there is some say drawback, I would say.
Yeah,
In
that was my biggest question after reading the article, and then certainly after talking about it on the research brief, is they divided. So they obviously had a high number of patients had directional preference, high number of centralization, but when the authors displayed those numbers, they related it to either a flexion or an extension directional preference. And I'm talking to Anya Franz next week. We're going to be chatting for a brief discussion. That's one of the questions I have for her is, are they, she classified only as flexion or extension responders, and where do those lateral responders fall into that cohort? Another big thought for me was what happened to the patients in the other treatment group that didn't receive mechanical diagnosis and therapy assessment. I think it's a big loss from the overall quality of the study is that you don't know the classification of the patients that weren't treated by MDT. So therefore, we don't know the prognosis of those patients. We know MDT can help direct patient prognosis, which I know in some of the upcoming research and literature is saying, should we really be falling away from the idea of diagnosis entirely and really just focusing on, what's the patient's prognosis? Because that's what we really care about.
Exactly. I think sometimes we may not be very perfect on coming on the diagnosis part. We can go ahead definitely with a provisional diagnosis and see how the patient's symptoms and functional improvement is going on. I think that would make more sense rather than trying to come to the complete conclusion of a provisional diagnosis or confirmation of the classification.
Yeah, and so the classification in a way leads us to prognosis. However, the term of the classification and the term of the diagnosis maybe not so important because the patients are coming in at the end of the day, they want to get better.
Exactly. Yeah. Yeah. At the same time, we also want to be very careful in giving out diagnosis because sometimes that diagnosis can influence the patient's behavior.
Mm-hmm.
I would explain whatever the diagnosis is. I would explain that to the patients in their own terms, depending upon the educational level of the patient. Whether if they already are in the medical background, I can explain them in depth. But like for patients who are not medically educated or like if they're not too much into the medical terminology, then I definitely come down to their standards of understanding the diagnosis and pathology rather than just giving a label of diagnosis than making them scared about their problem.
It's a little tough sometimes. I 100% agree with what you're saying. But sometimes as patients come into our office with that, we almost call it a checkbox that you have to hit certain things to make the patient more or less satisfied with the results of the examination that you're getting. And regardless of their education level, some people are coming in and they're like, okay, I got my diagnosis. That's a checkbox. I am therefore more satisfied than when I came in. as a result, and of course may relate to their outcomes. But it's all interesting. Did you have any takeaways or action items as a result of kind of this observational study that occurred in the Franz 2017 study?
Not specifically. Not specific. Yeah.
One thing that I'd like to see kind of follow up with a study like this, they had a few patients that were diagnosed without a directional preference, and unfortunately only 22 patients being in Anya's treatment arm. There weren't enough patients to do any sort of internal analysis with regards to how those patients fared as opposed to all the other ones with the directional preference. It's kind of clinician versus other treatment clinic. It'd be interesting if there were a larger sample, if they were able to find out a little bit more information.
I agree. Yeah, yeah. The larger patient sample would be giving us much more information.
Mm-hmm. Well, we've got time to cover one more research article here. We'll talk briefly. We discussed before the Fazey study that looked at the MRIs and the direction of how the discs move. We've got the Albert study that looked at centralization prevalence in different disc types. And then we also have the Adrian Louw study from 2020 that looked at the effects of the history on patients' outcomes. Anything in particular you want to chat about any of those three articles?
Let's talk about the Fazey article on the disc bulges or the disc derangements.
What do you think about that study? How does it relate to how you might approach or educate a patient based on their presentation in your clinic?
So in my clinic, I would try to balance between the biomedical approach of pathoanatomical approach. The second one is the non-pathoanatomical approach of the McKenzie Method or the MDT, and the third one is the biopsychosocial approach of Gordon Wadu. So I try to balance between these three systems because when I do the assessment and give the clinical reasoning to the patient and their families, like explaining about what's going on and all, I have to be answerable to three people in the room. One is Nikolai Bogdak, and second one is Mr. Robin McKenzie, and third one is Gordon Wadu. So I try to maintain the balance because sometimes we just don't want to ignore or like completely take away just the biomedical approach. We wanted to and we always follow the non-pathoanatomical approach because it's much more like it's most evidence-based than the biomedical approach for treating most of the musculoskeletal conditions. But at the same time, I would not try to take away the value of the biomedical approach and the biopsychosocial approach in treating the patients with this non-pathoanatomical approach of the McKenzie method. I would be taking the baselines from whatever the patients bring, like if they bring their MRI reports or X-ray reports or any other ultrasound guided imaging. I would take them as a baseline, and I would explain to them as a part of our assessment that we need. It may be useful, or it may be, if it is relevant or non-relevant, based on what we're doing in a non-surgical physical therapy method.
Yeah, and I love what you said there is kind of you're answering to three different people in the room, and I love Bogduk's work. I appreciate him very much, and then obviously I have McKenzie, and then Waddell as well. So that's a beautiful analogy used. It's interesting with this particular study because depending on who comes into your room, based on how you need to educate the patient, you can either use the literature from the Fazey study in your kind of to support what's happening, or even from a biomedical approach, or even to refute it. So the Fazey study looked at a high relationship between flexion and extension of the spine, and the disc happened to most frequently, almost 100% of the time, 19 out of 20 times, moved in the same direction as what we would expect. More the Bogduk side of things. And then when we looked at the lateral movements, it was almost a 50-50 split. half the time the disc, they were doing the left rotation, half the time the disc would go to the right, half the time the disc would go to the left. And so you can kind of almost bias that information from this study to talk to the patient that either needs confirmation that yes, the disc is moving where we're going, because maybe this movement agrees with that the result, or we're getting a completely unusual response and we can justify it because sometimes it's a coin flip anyways, wherever that disc may go.
Exactly, I completely agree with you, because our repeated movements and mechanical treatment may not, we don't definitely need the follow-up of with repeat MRIs or repeated X-rays to follow up with like where the disc is, or what is the status of the muscle or the bone and the cartilage tissue. So patient symptoms and functional improvement makes more sense rather than the imaging results or the pictures on the MRI.
Yeah, and we can get hung up so much, even though symptoms are improving, but where's the disc at this current point in time? But hopefully we move a little bit away from that in future time points. So any action items, any takeaways from this particular article, anything that really stuck with you as we're wrapping up here?
I mean, this article greatly supports our non-patho-anatomical approach of the McKenzie Method and the MDT system. So I think it's a good article that supports the MDT approach in treating the MSK musculoskeletal problems. So I really appreciate that article supporting. It's a good supporting article for us.
Yeah, and then on the other side of things as well, you get the patient that comes in with a disc problem. It's protruded, bulged, herniated, what have you, and it's further justification that we know, hey, you figure that by this point in time we're well comfortable with that as a population as a whole. But again, further justification that the disc still moves when we move, and and so here you are for the right reasons, and let's get on with moving it. So. All right, Naga. Well, I appreciate you spending time with me and in getting on here to help me promote the show. And hopefully you continue as a listener. So Naga here is an excellent participant in our Facebook group that we have, our closed group to discuss. He's always contributing research articles. Another great reason for asking you to come on and do this with me. But also other resources that you have available are at the mskresearchbrief.com website. There are supplementary PDFs to take advantage of. And anybody can feel free to reach out to me as well at mskresearchbrief@gmail.com. And hopefully you enjoyed this interview process here. There will be more to come in the future, and feel free to reach out with any feedback. All right?
Thanks, Michael.
All right. Thank you.